Iceland has about 11 publicly operated ski hills. Most of those ski areas have only surface lifts, while 3 areas operate chairlifts. One of those ski areas, Hlíðarfjall in Akureyri, is in the north, while the ski areas that we operate are in the southwest. Skálafell has 1 chairlift and 3 surface lifts. Bláfjöll, our main ski area, has 3 chairlifts and 12 surface lifts. We also have about 20 kilometers of cross-country trails. These 2 ski areas serve the capital region of Iceland, which has a population of about 250,000. Bláfjöll has a service center with a cafe, ski rental, and a first aid station. There are also a further 4 huts that are operated by the ski clubs. We employ 2 full-time ski patrollers and some part-time patrollers as well. Our roles are piste safety, piste rescue, chairlift rescue, avalanche hazard assessment, and general assistance. Ski patrollers are trained as either wilderness first responders or emergency medical technicians. We use both snowmobiles and skis or snowboards. We have also avalanche training from Iceland Search and Rescue and the Canadian Avalanche Association. Our snowmobile is equipped with first aid equipment including basic life support airway management, vacuum splints, and femoral traction splint. When skiing, we carry a bag with first aid equipment, tower escape kit, and a basic avalanche rescue kit. We use Cascade rescue toboggans that are pre-equipped with a warm blanket and a vacuum mattress located strategically at the base of our runs. We also have a Cascade toboggan for towing at our cross-country area. We also have a scoop stretcher to help us load persons onto the toboggan in difficult situations, and a spinal board, which are now rarely used. Accidents are usually reported by fellow skiers to the nearest lifty or the control center. Calls will also arrive from the national emergency number 112. Ski patrol will then be notified by radio. We approach most accidents at first from the base with a snowmobile. When the patient is located, we start by ensuring the patient's safety, often by parking the snowmobile above the patient with blinking lights. We start with assessing ABCs, get a quick history, and do a quick trauma assessment to determine the next steps, whether the patient is mobile and can be helped onto the snowmobile, or whether the patient needs a stretcher. We would then call the control center and request a stretcher. If we determine an ambulance is needed, we would most often call 112 prior to asking for the stretcher, as it takes longer for the ambulance to arrive than for us to bring the patient down in a stretcher. On steeper runs not accessible by snowmobile, we will bring the stretcher to the top of the run using a snowmobile and ski down with the stretcher. We also have crampons and ice axes for mobility, as our mountain can get very icy in our maritime climate. The command center will organize a stretcher to be brought up by an available staff member, usually an area manager who is normally in charge of lift operations. He will then assist in loading the stretcher by holding it in place. Depending on the patient's condition and assessment of the situation, we will either remove the vacuum mattress from the stretcher or place the victim directly into the mattress while still in the stretcher. When required, we will use a scoop stretcher to load the patient onto the vacuum mattress. When placing patients on a vacuum mattress, the emergency hospital requests us to always try to place a bed sheet between the patient and mattress for easy extraction in the hospital. We then wrap the patient in a warm blanket. On our ski runs, we generally ski down with our stretchers. Exceptions might be made for steep and technical terrain where we might use ropes, or very gentle terrain where we would tow using a snowmobile. On most runs, we will need to tow the stretcher up to the first aid station. This is achieved by clipping the toboggan belay line to the snowmobile and wrap it around the stretcher rope to create a releasable friction hitch. When we need to retrieve injured persons from the cross-country area, we use a cascade toboggan with a snowmobile tow bar. Once we arrive at the first aid station, we will carry the vacuum mattress inside to keep the patient warm and to make further assessments. We communicate with the ambulance service 112 and other first responders with Tetra digital radios. These work through receivers across the entire country and are monitored by GPS. The ambulance will most often come from the Reykjavik Fire Department. If we have not brought the patient down before the ambulance arrives, we will transport a paramedic to the scene. Occasionally, we will transport the patient straight to the ambulance, but in most cases, the ambulance crew will do their initial assessment in the first aid station. We carry much of the same equipment as the ambulance, so if the patient is transported on a vacuum mattress or with a traction splint, we will swap with the ambulance so the immobilization stays with the patient. We aim to provide the same level of care as a basic life support ambulance. We follow ambulance service protocols issued by the Icelandic Out of Hospital Medical Director and wilderness first responder protocols from the Icelandic Directorate of Health. One area we hope to improve is pain relief. We currently only have ibuprofen and paracetamol, but would like to have a medical protocol for Penthrox in the future.